All right, welcome everyone. Thank you so much for joining us tonight for another one of our Vios Referring Provider webinars. Tonight's topic is something I think that is so interesting and that we are constantly collaborating on from the Vios physician perspective and so many of our referring physicians. So I'm excited to listen to all of you talk about this super important and interesting topic, because we're talking about recurrent pregnancy loss. Tonight we have from our Chicago region, Dr. Angie Beltsos, from our Milwaukee region, Dr. Ellen Hayes, and from our St. Louis region, Dr. Julie Rhee, and Dr. Mackenzie Purdy. And to get us started, Angie's going to kick us off.
Yeah, so thank you everybody for joining us. We're so excited to see everyone and of course have my amazing partners provide some of this incredible information that I think is very timely around recurrent pregnancy loss. And so what we've done at Vios Fertility is create some important centers of excellence around some very timely topics. And I think when we look at it, it's very important to go over the standard workup and treatment, but it also is important to individualize that care around a patient's both age, her prognosis, and also interestingly, we talk a lot at Vios about is what does her dream family look like? So as a woman, for example, might be 30 versus 40, and the 40-year-old wants a couple of children, I think that's an example of where you want to really be thoughtful, not only on test results, but also what they want to get out of the family they're trying to create. So I think when we look at the most common cause of miscarriage, almost 2/3 of miscarriages happen because that particular egg and sperm, when they came together, there was a mistake. And so this embryo ended up with too much or too little DNA from mom or dad. And it's very interesting. Some of these things, people wonder, does it happen because the egg, when it arrives on the scene, is that by itself abnormal? Or is it when the egg and sperm actually come together, and could the sperm be impacting that as well? We do see a very clear distinction between women when we talk about, in obstetrics, advanced maternal age. When we look at women trying to conceive, women that are less than 35, once they are pregnant, the chance that they would miscarry would be significantly lower. Of course, hitting that 35 mark, the numbers go up, but by the time a woman hits 40, the miscarriage rate can be as high as 75%. And there's some very interesting studies around that number. But if you do a beta HCG on 40-year-old women with or without a period at the time of their period, and whether they're on their period or not, you'll find miscarriage rates are pretty high depending on how you define that. The other piece, though, is that sometimes miscarriages happen even when the genetics are normal. So if you find, there's a very interesting study that when you put a camera in, even via hysteroscopy, and look at that embryo, physically it looks like up to 20% of those embryos that have miscarried actually look physically abnormal. So everything isn't in the DNA. Sometimes vital structures like brain, heart, if they're not developing properly and end up having significant physical anomalies, you can see those even early on. Next slide. So as we start to explore the evaluation, of course, the timing of when testing begins may vary, but the American College of OBGYN and the American Society of Reproductive Medicine define recurrent pregnancy loss as 2 losses in a row, although for our board exams in the past it may have been 3. We really look at 2. And when we start to look at why someone's had 2 or 3 losses in a row or potentially more, over half of them we will be able to identify a cause. And then we also know that many couples with RPL may have a negative workup and everything comes in normal. So I'm going to hand the talk now off to my partner, Mackenzie Purdy, who's in St. Louis.
Hi, everybody. Thanks for joining in. I know most of you are aware of the basic evaluations, which, we'll go over briefly, but then we kind of want to talk about some of the more, deeper things you can get into, things that maybe might be a little bit controversial. And then certainly we're happy to hear your questions about, individual patients and things like that. But, based on ASRM recommendation, ACOG recommendations for the general evaluation, we know that it's important to look at the uterine cavity. And there's multiple ways to assess that, but in that instance, you're hoping to determine if there's a Mullerian abnormality, and then look for any type of physiology that would potentially impact an implantation. And then for blood tests, there's going to be a wide array of things, and this gets down to the controversial topics we might get into later, but based on what ASRM and ACOG recommendations, we know that we want to do genetic testing in the form of a karyotype. We know we want to check hormone levels in relations to the thyroid and hemoglobin A1C for diabetes. And we specifically want to look at antiphospholipid antibody syndrome, as that has been shown to have significant impact. And we'll talk a little bit about thrombophilias, which are somewhat in the same vein, but we know are pretty different in relation to what the recommendation says. Next slide. So uterine cavity evaluation, a lot of this is our bread and butter, but if it's not, it's definitely reasonable for any patient who has recurrent pregnancy loss. Like we said, that we're typically investigating around 2 or more losses based on the ASRM recommendation. And this can be assessed typically best by a saline sonogram. And, it's interesting, you do a transvaginal ultrasound and, maybe you see something that looks a little bit abnormal. The saline really just gives you so much more by giving you that opening of the cavity. And then we've actually gone to doing a saline in combination with doing a 3D ultrasound, which really has helped us get, better parameters and specifics. So for a septum, we can really tell how deep that septum is, and that helps with surgical planning in regards to that. And then hysterosalpingogram is not really a standard of care, but it certainly can be used to assess if there's a Mullerian abnormality. And this is one of the really important evaluations, because we know that women don't necessarily have a high chance of having a uterine abnormality, but if they have recurrent pregnancy loss, it can be upwards, the range is huge. All of the studies, some of them go up to 30 to 40%, but if you're looking at the average across most studies, you're still looking at that 10 to 15%, which is a decent chunk. So you're probably going to pick up quite a few patients and if you're doing your uterine cavity evaluation. All right, next slide. So like we said, I know you guys know all of this, that septum is probably the most common thing that we're going to run into, and certainly has the most effect on pregnancy loss. So the studies basically show that you can improve pregnancy outcomes by probably 65% by doing a septum resection. So I always think, if you're going to do something, you definitely do that little bit of blood work, but definitely do that cavity evaluation, because the risk reward is certainly there. So, septum, the definition is typically arcuate. We say less than 1 centimeter. We don't think it has a huge impact on pregnancy outcomes, although that has been debated in the past too. There's a couple studies that came out to say it's possible, but overall ASRM stands by the fact that less than 1 centimeter, we're not typically recommending resection because there's not a ton of data to support that. And then greater than 1.5 is the strict definition for a septum. I would say that in our practice, a lot of times, if they've had a history of recurrent pregnancy loss at greater than 1, we're going to recommend resection. And this is a huge part of our life too, because we do salines on a lot of patients just for infertility. And that's a whole nother issue in relationship to the fact that if they don't have recurrent pregnancy loss, but they have a septum, what do you do in that instance? And if you run into that, ASRM has a mixed standpoint on that if you have infertility but not recurrent pregnancy loss, and you have no other diagnosis for that infertility, it's not unreasonable to even consider a septum resection in that point. That's not the board answer, but it's definitely something reasonable to consider in your practice. But back to recurrent pregnancy loss, typically greater than 1 centimeter, we're recommending resection. Is that, you guys are pretty much doing that too, correct, Angie?
Yeah. I think that's a good point.
Mm-hmm. So Asherman syndrome, you might pick that up ahead of time. Obviously, if they have no, menstrual bleeding, things like that, but it's something that we can investigate, and any other type of rare Mullerian abnormality. Next slide. And then, I think one of the really interesting things to kind of dive into is a karyotype. And the data, I think, is showing that this actually is occurring. Balanced translocations are a little bit more common than what we've said in the past. The ASRM practice bulletin from 2012 quotes 3 to 5%. The most recent Spear-Off, which is kind of our Bible for reproductive medicine, has gone up as high as 5 to 8%. So it might be more prevalent than what we think it is. So getting a karyotype on both partners is a good idea. And we know for that patient, we explained to them clearly, you don't have the phenotype. We're not worried about you because you have a balanced translocation. But in an inheritance pattern, you have a 50% chance that your child is going to have an unbalanced translocation. And in that instance, a lot of them will go on to miscarry, and that would be the primary cause in some instances for why these women have recurrent pregnancy loss. And then this opens up another realm of testings and options for the patient. So if someone comes back and has a balanced translocation, or even very few people that actually carry the unbalanced translocation but have a very minimal phenotype, they have the option of doing IVF with doing embryo biopsy and then testing to specifically look for that genetic abnormality and then not transfer the ones that have the unbalanced translocation. So a lot of interesting stuff that can come up from a karyotype, and it's definitely important to make sure that we try and get both partners because certainly it could be inherited from either side. Next slide. And then I'm going to pass it on to Julie, Dr. Rhee.
Thanks, Mackenzie. Hi, everyone. Thanks so much for joining us tonight on your busy Monday evening. I am so excited to talk about recurrent pregnancy loss, as we know that it comes up a lot in your practices as much as it does ours. And I think, we'll get to this later, but I think Dr. Purdy brought up a really great point about there are some things that are textbook answers and some things that we actually do in practice that are a little bit different. So I think that's why this topic is so interesting, is because there's a lot of controversy, and I will be touching upon some of those kind of controversial points that that don't really have clear black and white answers. So the first thing is antiphospholipid antibody testing. So many of you are aware, I think this is kind of a big black box where it's really easy to forget about all the different criteria that go into defining this, this condition. So APLS, remember, antiphospholipid antibody syndrome, really by textbook definition, you have to meet both clinical and lab criteria. And so just to review the clinical criteria, if the patient has had a history of vascular thrombosis or blood clot in the past, and then pregnancy morbidity, it can be if they have had a miscarriage of a morphologically normal fetus past 10 weeks of gestation, or 3 or more unexplained miscarriages before 10 weeks once other causes have been ruled out, both paternal and maternal. Or another criteria can be 1 or more premature births before 34 weeks, suggesting placental insufficiency. So really that kind of would be the clinical criteria. Now on the lab criteria, which is something that you might need to review over and over again, because it is certainly a lot of acronyms and letters, but basically we test for lupus anticoagulant, anti-cardiolipin antibody, as well as anti-beta-2 glycoprotein. And so for the anti-cardiolipin antibody and the beta-2 glycoprotein, we do check both IgG and IgM. And by the strict definition, the patient, if they come back positive in medium to high titers, so depending on where you send off, you're going to want to look at kind of the reference range, because a lot of times you will have these equivocal results where patients will come back sort of low to medium titer, and then you're kind of stuck on what to do with that. And then if they do test positive, you do want to test 12 weeks later. So really, again, by the strict criteria, they do need to test positive in medium to high titers twice. So once they meet both clinical and lab criteria, then they're kind of under that umbrella diagnosis of antiphospholipid antibody syndrome. Next slide. So in terms of why this is important and how this can cause miscarriage and recurrent pregnancy loss, we think that having these antibodies can play multiple factors in terms of early pregnancy health. So we know that in order for for patients to have a healthy pregnancy, there's so many factors that go in early on, such as how the embryo implants into the uterine lining, how healthy the placental invasion is. So we think that these antibodies can inhibit placental invasion. There's also some theory that it can cause apoptosis of placental cells. And then furthermore, it can cause sort of this inflammatory response, which can lead to microclots or very small blood clots in the vessels at the time of implantation, which is why these women are more likely to have even not just early pregnancy loss in the first trimester, but potentially placental insufficiency later on and higher risk of preeclampsia and other obstetric complications. So the treatment for antiphospholipid antibody syndrome is low-dose aspirin, so baby aspirin 81 milligrams during pregnancy, in addition to heparin or Lovenox. So we say or Lovenox now, but it is important to note that the original studies were done with heparin. But now, because Lovenox is just easier to give and the dosing is just easier for patients than doing heparin twice a day, we do oftentimes, and usually MFMs are okay with us substituting Lovenox for heparin. Next slide. So other considerations, and this is kind of a slide where kind of how I mentioned earlier, there's a lot of controversy, and it'll be interesting when we talk in the Q&A to see kind of how we also, there are some differences in how we all practice as well. Endometritis, so chronic inflammation of the uterus, is thought to potentially contribute to early pregnancy loss as well. Now, I would say this is controversial only because if you look at the literature, there really aren't any really good randomized controlled trials to show that treating chronic endometritis leads to higher live birth rates in women with recurrent pregnancy loss. However, there are a couple of observational studies that have shown that if women who have recurrent pregnancy loss undergo an endometrial biopsy, chronic inflammation is found, and this is treated with antibiotics, that potentially in the subsequent pregnancy, they have much higher success, meaning, less chance of having another loss. But again, it's interesting because I wouldn't say that for all REs that we would agree that there's any sort of protocol that says anytime a woman with recurrent pregnancy loss comes in, one of the first things that we go to is to do an endometrial biopsy. There's also a theory about natural killer cells. So natural killer cells, are obviously really important actually in order for implantation to happen. There's this theory that if a patient has natural killer cells that are way too high in quantity, that this could actually have negative effects and cause recurrent pregnancy loss. I would say that this theory is also pretty controversial. ASRM, or the American Society of Reproductive Medicine, states that there isn't sufficient evidence yet to suggest that this is a potential cause of recurrent pregnancy loss. If a patient is found to have high natural killer cells on testing, the treatment for that is to give intralipid infusion. And certainly there are some REs and some centers that do believe that this could potentially benefit the patient. And again, this would be sort of figuring out the risk harm, the risk benefit ratio before you decide to do this. So I would say that it's pretty controversial whether NK cell testing is needed in these patients and whether treatment really does anything. And then in terms of thrombophilias or clotting disorders, I would say the ASRM has definitely changed their stance on this. Back in the day, we used to think that potentially if patients tested positive for any of these thrombophilias, they could potentially be at higher risk of recurrent pregnancy loss. Although there seems to be some studies that have shown correlation, that we don't at this time think that necessarily these are causes for recurrent pregnancy loss. So ASRM states that if the patient has a personal history of venous thromboembolism or a strong family history, it might be worthwhile to check for some of these, especially some of the more common ones such as factor V Leiden or prothrombin gene mutation. But I wouldn't say that this is part of our initial workup. Next slide. So I will turn the next topic of treatment options over to Dr. Hayes.
Thank you, Julie. And thanks everyone for joining us tonight. So obviously my amazing partners have described many, many reasons for recurrent miscarriage. And so I like to explain the workup for this to my patients is kind of casting a wide net, because we can't necessarily look at their history and say, oh, this is the reason. And we can't even assume that each miscarriage happens for the same reason. So a thorough evaluation is really important. And then we can really tailor treatment options to the individual or to the couple. So really some of the things that we may recommend after we have completed evaluation could be, for instance, a hysteroscopy or surgery to correct a structural abnormality in the uterus. As Dr. Purdy mentioned, that's most likely to be a septate uterus that we resect hysteroscopically with great success rates. It's a very straightforward procedure, and I imagine that many of you are comfortable doing that procedure as well. We will sometimes prescribe a course of antibiotics. Of course, if there's active infection in the uterus, but even for chronic endometritis that Dr. Rhee was mentioning, we'll often do a little bit longer course of antibiotics and potentially re-biopsy the uterine lining, and we can do special staining specifically for plasma cells to ensure that the endometritis has cleared. We would obviously treat any hormonal disorders that we find. So for instance, if we're finding thyroid abnormalities, if we're finding diabetes that's poorly controlled or newly diagnosed, and even in some situations, elevated prolactin, we'll treat that. Blood thinners for antiphospholipid antibody syndrome, as Dr. Rhee mentioned. So typically that will be a combination of Lovenox and low-dose aspirin in these patients. And then finally, we have the capability through IVF to screen embryos for either structural rearrangements. So in our patients with translocations, we can screen embryos and ensure that we're transferring an embryo that has either a balanced translocation or is not affected. And in other situations where we're really not putting our finger on anything specific, or in patients where we know because their products of conception have been tested and repetitively coming back aneuploid, in those couples, they often do very well with IVF with PGTA, or pre-implantation genetic testing for aneuploidy. So in those situations, they can go through an IVF cycle. We can biopsy embryos, test the embryos for chromosomes, and then ensure that the embryo that we're transferring is genetically sound to the best of our testing capabilities, and attempt to reduce their miscarriage risk that way. Next slide. There are definitely some things that patients can do and avoid as far as their own contribution to their miscarriage risks. So clearly smoking in either the female or the male partner will increase risk for pregnancy loss, as well as obesity in either partner. So when we see either of those situations, then we'll ask them to make some lifestyle modifications, live a healthier lifestyle, and therefore improve their chance for successful pregnancy. And then in those patients and couples where we aren't really finding a specific reason, it has been shown that psychological support and close monitoring, either in their OBGYN office or in an REI office such as ours, can actually improve outcomes in the subsequent pregnancies. So the way that we will follow patients, we'll often give them empiric progesterone to support the pregnancy, and we follow them with serial HCG levels early on to make sure they're rising appropriately. And then we perform ultrasounds to ensure that there's adequate and ideal growth and development of the pregnancy during the first trimester. And then we will pass them off to their OBGYN physician for their routine prenatal care. Next slide. So the take-home points are that there are a lot of things that we can look for in recurrent pregnancy loss situations. And it's important to really be thorough and not make assumptions based on history, but really be thorough and make sure you're kind of covering your bases with the evaluation. But when we check for certain conditions, we may not find a reason. And that is okay, because the overall prognosis for couples with RPL is still very, very good. They have an overall live birth rate of 70 to 80%, which we definitely share with patients to give them reassurance that if they keep trying, they're very likely to have a successful outcome. This is true for patients with a specific cause that we treat and those with unexplained recurrent pregnancy loss. So the purpose of the Center of Excellence for RPL is to assist patients in finding any treatable causes for their recurrent miscarriage and to supply them with evidence-based treatment options that are really specific for their particular situation. And I think at this point, we'll probably open it up for questions.
Yes, so we have a couple of questions that were sent in ahead of time. We'll start with those. But if you are curious or you have any questions right now, please send them in the Q&A chat box and we will get them answered. So we will start off with the question, if you find a septum during your saline and in an infertility evaluation, what's your stance on resection if it is greater than 1.5 centimeters?
Yeah, I'd be happy to take that question. So, going back to the data, there's not any great randomized control trial that said, yes, it's going to make a huge difference in relation to pregnancy outcomes. But are there smaller studies that have shown improvement in fertility rates if you do resect a septum and do not have a history of recurrent pregnancy loss? There are. So the ASRM, guidelines puts a little bit of a vague statement in there suggesting that if you do have a history of infertility without any real diagnosis, if you're considered unexplained but then found to have the septum, is a reasonable treatment option to consider doing a septum resection. And I would say probably in all of our practices, I'll let them chime in. If someone has a history of infertility, done most of their workup or all their workup and haven't found any specific reason, I'm going to counsel them, and some of it will depend on just the size of it, right? So if you have a septum that's coming down into the internal os of the cervix, to me that's a little bit more concerning than one that's only taking up a small portion of the uterus. But I would say overall, if they do have a larger septum, 1.5 or more, then I'm going to offer resection if I don't have any other cause for their infertility. And I don't know if I'm looking at my other panelists, but I think that's kind of pretty typical.
Yeah, I would agree. I would agree with that. I think, obviously in our infertility population, we're doing testing and we may find a septum as an incidental finding, right? Because they've never had the opportunity to be pregnant and have a miscarriage, but we don't want them to proceed with potentially expensive and emotionally expensive fertility treatment just to have a loss. So I definitely always counsel patients about the option of surgery and, the pros and cons.
Yeah, and I was just going to say, Ellen, I'd like to also add that, if you think about why physiologically a septum can cause pregnancy loss, that fibrous portion, we think that there's minimal vascularity there. So if an embryo happens to implant on that septum, perhaps, again, due to issues with placental invasion and just sort of implantation failure, it can potentially cause a loss. And all that to say, although we measure septums on ultrasound and on salines, that's always just an estimate. And so when you actually go in to resect these septums, it's interesting because sometimes they look minimal on saline, but you go in and you find that it looks very fibrous. And then once you cut into it, you realize there was really actually no blood flow there. And so people often will ask, how do you know when to stop cutting a septum? And oftentimes we'll stop cutting when we start seeing good vascularity and good blood flow to that area. So it's just interesting, that we see that when we actually go in to resect the septum.
Yeah. And to follow up on all those excellent points, another thing is that it is a pretty non-invasive procedure today via hysteroscopy, and we can even perform that in our offices, so it doesn't require so much of an abdominal approach. And when we do these, you can also do it with an transabdominal ultrasound. So you can actually see very nicely how much myometrium is in front of that hysteroscopy, so that when I was taught, it was like do a laparoscopy concurrently. And then once you see the hysteroscope light coming into the field and you shut all the lights down and you're like, all right, well, now we're really close to perfing her, we should stop. You know, I think by ultrasound and these non-invasive techniques, you can really do quite a lovely job right there. And then right after the hysteroscope, you can do a saline 3D with our machine, so we see if there's any areas that could be refined. Beyond miscarriage and failed implantation or poor placentation, there's also less room, so they're at higher risk for potentially preterm delivery and preterm labor and preterm delivery. And finally, with that wedge in place, there's a little higher risk of C-section for malpresentation. So I think for a variety of reasons, partly due to what Ellen, you brought up is a really important question, is like they haven't had a chance to miscarry, but God forbid you do all this and that's why they miscarry and it could have been corrected. However, not everyone will miscarry. I was telling a story that I had a patient come in with 3 full-term deliveries. She had an HSG done after a tube ligation. She was remarried and they had brought in her initial workup, and her cavity was like deep septum, and like how many people with these actually do just fine. And so none of this is absolute, but I do think that's a great question that Elena asked us. And I think you can probably go either way. I remember one attending would say, we're not doing anything to these septa until they miscarry 3 times.
So thank you for that. Another question is, Ellen, I think this is in reference to maybe what you were talking about near the end of your slides, but can you discuss the use of progesterone for support that you were talking about?
Oh, definitely, definitely. I mean, we check progesterone levels when we check HCG levels early in pregnancy. The difficulty comes in because it can fluctuate. It can fluctuate during the day. It can fluctuate day to day in the same individual. And so we have a pretty low threshold as REIs for supplementing progesterone. And it's fairly easy, you know, it's not going to be harmful for the pregnancy. We often give it in the form of vaginal support versus oral. But that can depend on the particular situation. But really the purpose is to maintain, you know, a very stable progesterone level early on during the implantation phase and during the first few weeks of pregnancy, when the corpus luteum is producing hormones until the placenta takes over. And they typically will not need any supplementation beyond, you know, the 8 to 10 week mark. Sometimes in recurrent miscarriage patients will continue that a little bit longer depending on when they've had their losses and continue to more like 12 weeks. But I think we just have a low threshold because we know how important progesterone can be early on in the pregnancy.
Awesome, thank you. Dr. Beltsos, can you talk about what role sperm may play in RPL patients?
So it does take 2 to tango, and there are some interesting studies looking at couples that are getting pregnant but miscarrying. And so we know that there's a quantitative measure of sperm done by semen analysis, count how fast they swim, what percentage look like they have the right shape. And then there's qualitative measures where we're looking to see if the DNA of sperm is breaking apart very quickly. Interesting, if you look at sperm DNA, it actually is loosely packaged so that when it arrives in the egg, it can be quickly unpackaged and fused with the egg DNA. And some men, their sperm is actually quite fragile. And by that, once, even though the count's there and the motility is there, it actually fragments very easily. And so high DNA fragmentation, sperm that, if you will, crumbles very quickly, has been examined. And there's some studies showing that that happens more commonly in recurrent pregnancy loss. One of the recent studies was a meta-analysis, and it had taken 13 studies, and meta-analyses of course, have advantages because you can take small numbers and put them together. And then there are disadvantages because you're putting different research trials together. However, there was an association in this particular study that high DNA was more common in the recurrent pregnancy loss group. So at Vios, we can test that in patients, but we were talking earlier just about tiering what we do, the ASRM guidelines on what you do for recurrent pregnancy loss. And then if those are normal, you know, you start to go out to these other tiers, and DNA fragmentation may be a consideration when your other studies come back normal.
Awesome. Thank you, Dr. Beltsos. Dr. Purdy, can you talk a little bit? We got this question from several people. Can you talk about MTHFR and pregnancy loss?
Yeah, so MTHFR, we know, is part of the folic acid mechanism. And this was a pretty interesting topic probably closer to 5 to 8 years ago, when we thought that potentially if you had a deficiency in MTHFR, if you had an abnormality, then you might be at a higher risk of miscarriage. So MTHFR is inherited in a recessive trait, so similar to things like, you know, cystic fibrosis and that kind of thing. So if someone has a gene abnormality, they could either be a heterozygous or a homozygous. Probably, you know, what the data in the past, the limited data that had been presented, was that potentially for a homozygous deficiency or gene abnormality, you were at a higher risk of having pregnancy losses. And in that instance, there was a little bit of swing to say, why don't we treat these women with anticoagulation? But there really wasn't any significant randomized controlled trials or larger data that had supported doing this. So we know now there's been some larger trials that have been presented and have shown that, you know, regardless if you're a heterozygote or a homozygote, there's not necessarily an increased risk for recurrent pregnancy loss. And it comes back to what Dr. Rhee was saying in relation to the fact, is it, you know, correlated or is it causative? And I think there's, you know, some correlative associations with MTHFR gene abnormalities, but not necessarily any good studies that have shown a causative effect for that. So ASRM doesn't really recommend testing for that and doesn't necessarily recommend treatment for that. So you know, the hardest thing is, we were talking before we actually got on this, is what do we do? You know, it has been tested in the past. It was kind of a popular thing to test for. What do we do? We have a patient that comes in and has it and feels very adamant that they need to be on some sort of anticoagulation. I think, you know, we all talked about, you just have to weigh the risks and benefits. A baby aspirin risk, you know, seems pretty minimal. And I think if, you know, a patient is pretty adamant that that is a treatment they've been on before, to me, I would be fine with doing a baby aspirin, just because risk-benefit is not really worrisome to me. I think I'd really have to think about Lovenox or heparin in relation to that, and, you know, talk about the studies, certainly, you know, support the OB that's prescribed it, because you know, there's certainly other data out there that we don't always know about. But I would say in general, we're not going to start someone on that medication, but would analyze it on an individual basis.
Awesome. Thank you, Dr. Purdy. Dr. Rhee, this next question is for you. Do you routinely do endometrial biopsies on RPL patients?
That's a great question. So I don't think there's a right answer for this question. I would say I don't routinely do endometrial biopsies. I think a lot of the times when we decide whether we are going to move forward with something that there's lack of data on, you know, we've kind of got to, again, weigh risks, benefits. And endometrial biopsies are painful. They're somewhat invasive. You know, sometimes insurance doesn't cover it if they're not coded properly, et cetera. Having said that, we do know, like I said earlier, that if a patient, you know, if you do the staining and they come back positive for chronic endometritis, there are some correlative studies that show that treating the chronic endometritis and then potentially doing a test of cure to make sure that they've cleared that infection can increase their chances of having a successful pregnancy. And there are also, you know, kind of studies that have looked at different groups and have seen a higher live birth rate, although one could argue whether that was clinically or statistically significant or not. Some of the studies, you know, definitely weren't very strong. So to answer your question, I don't routinely do it, but if we've ruled everything out and their workup has been negative, you know, what you've got to realize, and what I've come to realize over the years, is that patients, when they come to see both a physician as well as a reproductive endocrinologist and a fertility specialist, really they're looking for answers. And it's kind of unnerving for patients to be told everything looks fine, you have a 70 to 80% chance of having a healthy live birth, so go home and keep trying. So certainly we want to be mindful and thoughtful of not, you know, kind of just willy-nilly doing things where there isn't good evidence for. But we really do, I have a conversation with my patients, if everything comes back negative, that potentially we could do a biopsy, and if it comes back positive, you know, treating, and usually it's oral antibiotics for 10 to 14 days, and then doing a test of cure. But, you know, this is a pretty big topic, so I'd be interested to hear what some of the other panelists do.
Yeah, I agree. I think this kind of goes along the lines of what Dr. Beltsos was talking about, as far as kind of a tiered approach with some of these tests that are maybe not quite as mainstream as the traditional ASRM guidelines and workup. So I definitely keep that in mind. And in certain situations, I'll do the endometrial biopsy kind of right from the get-go. You know, every patient that sees us doesn't necessarily meet perfect criteria for recurrent pregnancy loss. And so sometimes we'll see patients who have had multiple biochemical pregnancies. And so sometimes I get more suspicious with different patient history, and an endometrial biopsy might move higher on my list. But I definitely keep it kind of in our hip pocket, like the DNA fragmentation, when other things have been excluded. I think all of us have seen that it can be fairly significant in certain patients. It's just not necessarily, you know, a common finding.
Yeah, it's something that I don't routinely start with, but I think it was provocative to kind of think, where does that fit in the paradigm of their workup? And say, you know, when do we do it, and how do we end up managing it? So it is helpful to kind of have a recipe for what you do when certain kinds of problems come in. And so I like the idea of having that in our armamentarium, especially when the first basic tests are done and the testing comes back normal.
Yeah, I could agree with all of you guys. You know, you think about your arsenal of things that you're going to do. Someone comes in, you're definitely going to do your basic workup based on the ASRM guidelines, and then individualize it based on, like what you said, Dr. Hayes. You know, if they have a little bit more of a rationale to maybe have an earlier loss, like a biochemical, is that related to endometritis? We don't have good data for it, but the risk reward, you know, you have to balance that and then talk to your patient about it. And then I think it's not unreasonable to consider doing it.
Yeah, and then the other thing is that if they're already going to do a hysteroscopy, either diagnostic or if they have a polyp, certainly it makes sense at that point to just do a biopsy and send that sample off. And then also, I think there have actually been a couple studies to show that in women without recurrent pregnancy loss, if you were to just randomly take an endometrial biopsy, it's a pretty substantial percentage of patients that that you will have that incidental finding of chronic endometritis. So it makes you wonder, you know, again, is it causative or is it just correlative? But I think that's kind of the interesting thing about what we do, is you have to take every situation, you know, kind of differently.
Yeah, that's for sure. One of the routine things that we were talking about was karyotyping, and lately they now have the standard karyotype and then high resolution karyotype, and things that seem so simple, it was just do a karyotype and then we're good to go. But now high res is starting to become something. The high res is where it looks a little deeper into the DNA. With a standard karyotype, you can get about up to 550 bands, and it gives you, you know, looking for these micro deletions or little breakpoints, whereas high resolution is 550 to 800 bands, and some of your patients now are asking for high resolution karyotype. So I don't know if you guys have had any experience on that.
I haven't had anyone ask for that per se, but you know, I think that I've sort of switched over to ordering the high resolution. I just think as technology advances and the more information we can get, these are tough situations. And, you know, in the past, we had to tell 50% of RPL patients that we just couldn't identify what the problem is. And I think as testing gets better, things like high-res karyotype make a lot of sense to kind of catch more things in our net.
Yep.
Well, speaking of genetics, we have one more question that I think is a great one that maybe you all can answer, because maybe there's a difference here. But when would you recommend that products of conception are sent for genetic testing?
Well, I would suggest, you know, I don't think anyone would necessarily recommend with a first miscarriage that's necessary to do. I would suggest, because we're often going to start evaluating patients after their second loss, that sending the second set of products of conception for karyotype testing, but specifically the more sensitive 24 chromosome microarray testing is incredibly helpful. So I think anything past the first loss is what I would recommend, just for our information, for the patient's information. It really kind of sets us forward in this evaluation and gets us off to a good start if we know whether the pregnancy was euploid or aneuploid.
I agree with that. I agree with that. I mean, you definitely can open up a can of worms, and that's why some people maybe don't consider doing it for the first loss, right? Because sometimes it's too much information for a patient, and if you don't necessarily have much to do with it, then it's not as helpful. So, you know, thinking about someone who comes back and it's normal, you know, a lot of that is an emotional toll on someone to say, well, what are the other reasons why? And you've done a workup and there's not necessarily anything else. I think it's interesting, you know, Dr. Beltsos was talking about the fact that even if it comes back and it's chromosomally normal, we can't say with certainty that it didn't have some sort of structural abnormality. And that's, you know, I try to keep that in mind and tell my patients that if it comes back and it looks normal, but it's not to say 100% that it wasn't an embryologic cause for the loss, but it does, you know, reduce the chance that that's probably what it is. But I'm of the same, you know, thought that I would typically recommend for the second pregnancy loss, along with the workup, just to get the products of conception.
Yeah, I was just going to say that I think probably the most important part of sending the products of conception off for testing would be to counsel the patient beforehand about how you're going to utilize that information. You know, and I think we know that greater than 90% of miscarriages are due to chromosomal abnormalities. So most of the time it will come back abnormal, but I think it's also important for patients to know that, you know, what do you do with that result when it comes back normal, right? And so patients often think, if it comes back normal, does this mean that I can't ever carry a pregnancy? Does this mean that I have an abnormal uterine factor that we just can't pinpoint? And the answer to that is no. And just like Dr. Purdy said, I think it's sort of hard. It's a little bit of a nebulous idea, and it's not very concrete. But even if the tissue testing shows that it was a normal fetus, meaning normal number of chromosomes, remember that's just looking at chromosome copy number, and at the end, it really still could mean that there is some sort of maternal fetal abnormality that caused that miscarriage, right? So I think it doesn't necessarily give us a clear-cut answer, but at least it gives you one more kind of data point. And I think with recurrent pregnancy loss, any data is better than, you know, any more is better than less. So I agree. I think once they come see us, if they do have another miscarriage, I think most of us probably would be more inclined to do the POC testing.
Awesome. Thank you guys so much. Thank you to everyone who attended today. Thank you to our 4 wonderful Vios physicians for joining us for this great discussion. I do just have a quick exit poll. We are, this I think is our 3rd referring provider webinar this year. We really enjoy doing them and we want to continue to make them helpful and useful for you. So I'm just going to launch a quick poll here. If you could answer these 2 questions, how helpful was this webinar for you? And what would make events like this more useful for you and for your practice? If you could just take a moment, would appreciate that. Wonderful. Thank you so much, everyone. Thank you, Dr. Hayes, Dr. Rhee, Dr. Purdy, and Dr. Beltsos for joining us tonight. And as always, we're recording this and we will be sending a copy out to you guys, and you can share that with your practice.
Awesome.
Thanks, everyone.
Thanks for joining.
Joining us.
Have a
Enjoy
good
your
night.
evening. Thanks.
Thank you.
Bye, guys.
Bye. Good night.